Hello, healthcare practitioners, subject matter experts, aka SMEs, and other interested parties. My name is Pete Melrose, and I'm pleased to welcome you to this half-hour presentation entitled Do-It-Yourself Apps for Healthcare Practitioners. Throughout my 50-year healthcare information technology, or IT, career, including roles as NIH Project Research Assistant in the 1960s, IT analyst and programmer, hospital chief information officer, consultant, and entrepreneur, and for the past 10 years since my retirement from IBM in 2013, I have pursued a vision for healthcare digital transformation predicated on the hands-on use of computers by healthcare subject matter experts with little or no IT expertise. The purpose of this presentation is to inform you about and encourage you to use the current implementation of that vision, a do-it-yourself or DIY internet cloud-based toolkit for SMEs to design, develop, deploy, operate, and optimize software applications or apps for real-time cognitive support of your own customized best practices and other clinical and administrative rules-based processes. The degree to which you appreciate and apply the content of this 30-minute presentation will determine the velocity of a much-needed and long overdue transformation that leverages human-computer collaboration for significant improvement in the cost-effectiveness of health maintenance and care, a digital learning health system. This presentation follows the clinical case management model to understand need and propose development strategy for a digital learning health system. The 6 sections are as noted on the slide. 1. The presenting problems, including medical mistakes, misuse of IT, and resulting practitioner moral injury. 2. The case workup, including healthcare complexity, concurrency, and chaos. 3. The diagnosis or root cause of the presenting problems, which I posit to be human cognitive limitation and overload. 4. The plan to address the problem and diagnosis, which is the implementation of a digital learning health system. 5. A representative case study that compares and contrasts current cognitive tools and methods with the proposed digitally enabled real-time cognitive support. And 6. A call to action for you to use the do-it-yourself cloud-based solution as a service that is available beginning Friday, July 8th, free of charge, to create and operate your own apps. In the interest of time, the explanation and rationale that I will provide for each slide is minimal, but I encourage you to interrupt the presentation at any time to consider the slide content and the references cited in order to satisfy yourself of the validity of the proposed premises and the feasibility of expected results. The professional and popular medical literature both have documented and decried the extreme frequency of medical errors and the resulting incidences of preventable patient morbidity and mortality. In particular, the historic and oft-cited Institute of Medicine November 1999 report, To Err is Human, asserted that, quote, at least 44,000 people and perhaps as many as 98,000 people die in hospitals each year as a result of medical errors that could have been prevented, end quote. Almost 2 decades later, in May of 2016, McCary and Daniel of Johns Hopkins Medicine reported, per graphic numbered 1 on the slide, that at least 251,000 U.S. patients die annually because of medical mistakes. Other similar studies during the intervening years have estimated preventable patient deaths at from 220,000 to 440,000 domestically and 4.8 million globally. The table number 2 reflects a steady increase from 2015 through 2020 of medical mistakes, aka unintentional injuries in the current literature, which ranking was reduced from 3rd to 4th beginning in 2020 owing to the occurrence of the COVID-19 pandemic. The principal cause of medical mistakes, aka unintentional injuries, was no mystery to my now deceased healthcare IT mentor and inventor of the problem-oriented medical record, Larry Weed, MD. In the overview section of his 2013 book, co-authored with his son Lincoln, entitled Medicine in Denial, Dr. Weed recognized that, quote, essential to healthcare reform are two elements: standards of care for managing clinical information, analogous to accounting standards for managing financial information, and electronic tools designed to implement those standards. Both elements are external to the physician's mind. Although in large part already developed, these elements are virtually absent from healthcare. Without these elements, the physician continues to be relied upon as a repository of knowledge and a vehicle for information processing. The resulting disorder blocks health information technology from realizing its enormous potential and deprives healthcare reform of an essential foundation. End quote. Moral injury among healthcare practitioners is a relatively recently recognized professional pathology that stems from protracted observation of patient injury and death with limited treatment tools and methods, and also limited personal protective measures, all of which has been exacerbated recently by the COVID-19 pandemic. Compounding the etiology of moral injury and its derivative depression and professional burnout are the cognitive and time burdens imposed by electronic health record (EHR) systems. These systems, known as systems of record, require significant time and effort for data entry, the completeness, accuracy, and timeliness of which are critical for optimizing hospital and health system revenue management and maximizing revenue, with arguably less benefit accruing to medical practice, care delivery, or case outcomes. Reduction in moral injury, which psychiatric pathology inevitably results in reduced productivity and burnout and retirement and even suicide, could be achieved by so-called IT systems of engagement that leverage system of record data to improve care delivery in real time and to provide real-time cognitive support with minimal concurrent record-keeping requirements. The DIY Apps for Healthcare Practitioners solution holds such a promise, as will be described later in this presentation. Given the presenting problems just discussed, this digital learning health system case study workup reveals signs and symptoms of extreme complexity, lifelong multi-venue concurrency, and chaotic practice venues. Furthermore, the object of medical practice and healthcare delivery is the complex human organism in a constantly changing state of homeostatic balance and control in a constantly changing external environment. Because homeostasis and other complex processes such as the Krebs cycle and cellular replication occur at the micro level in and among tissues and organs, the state of human individual and its included systems varies over time. Therefore, psychophysiological anomalies, insults, and pathological trends occur and change continually and unpredictably. So the sooner these potentially pathological variations are discovered, the greater the likelihood for success in medical intervention in returning the individual to its nominal state. All of these considerations imply the need for constant monitoring and analysis, which need traditionally has been impossible or not feasible because of the human limitations of healthcare practitioners, but which now are not only feasible but also practicable and even cost beneficial because of advances in information and other technologies. This schematic depicts the several states and venues implicated in individual persons or patients' health management in the context of the individual's conception to post-mortem life continuum, punctuated by outpatient encounters and inpatient care admissions as if required by illness or injury. Ideally, case-specific data and information would accrue to a worldwide common body of medical and healthcare knowledge in real time for immediate application to new patient cases and to current and evolving epidemiology and public health circumstances. However, owing primarily to the minimal adoption of medical information management standards and innovative health IT tools and methods described by Dr. Weed as previously noted, this knowledge management global goal has yet to be achieved. This slide, centered on the medical practice and healthcare delivery triad of patients, pathology, and providers, and its constant impact on healthcare practitioners, is included here as a reminder of the multidimensional, multidisciplinary, and multi-venue context that create the chaotic conditions under which healthcare is provided, all of which exacerbate the challenges to practitioner cognitive capabilities on which the delivery of safe and effective care depends. These excerpts from the reference cited in the slide by David Lewis, MD, express the good, the bad, and the ugly of so-called system-based thinking as it occurs in medicine. Quote, system-based thinking, SBT, describes a set of subconscious thought processes aptly named System 1, S1, and System 2, S2. S1 is characterized by fast, automatic thinking, while S2 is slow and activated when critical thinking is necessary. The profession of medicine relies heavily on SBT, the ability to rapidly diagnose, treat, and improvise during stressful situations is dependent on these systems, which develop and mature throughout one's training. However, frequent exposure, heuristics, shortcuts, and intrinsic biases can lead to medical errors and mistakes, making SBT necessary but highly flawed. Consequently, understanding how physicians develop and utilize these systems can minimize inherent errors and improve patient safety. End quote. Because the educated and sometimes subconscious S1, S2 interplay is fraught with error-prone heuristics and is inherently an either-or approach, we should be seeking ways to incorporate the two concurrently and creatively in ways that information technology can enable. To be effective in minimizing pathology and maintaining an individual's health, the increasing variety and volume of patient-specific data must be acquired, assessed vis-a-vis practitioner recall of pertinent current common body of knowledge specifics, applied to the case at hand, and then adapted to the specific individual in real time for the duration of the individual's lifetime. Because these requirements have been impossible to fulfill heretofore by a healthcare practitioner, owing to the 24/7/365 nature of the requirements for each of the average 3,000 patients in a typical general practice of medicine, therefore standards and practices for information management arguably have been compromised and constrained in the performance of medical practice and healthcare delivery to date. However, recognizing the current state of the IT art, it is necessary now to revisit and revise expectations for healthcare information management by providing healthcare practitioners with an IT-enabled, aka digital, real-time, and continuous cognitive support. Human cognition is defined as, quote, the mental action or process of acquiring knowledge and understanding through thought, experience, and the senses, end quote. Although the typical healthcare SME exhibits above average general knowledge and cognitive capabilities, these characteristics and capabilities can be degraded or disrupted by a variety of factors as previously described, complexity, continuity, and chaos, which have been correlated convincingly with diagnostic error by Pat Crosscarry, MD. Dr. Crosscarry's work makes a strong case for cognitive overload as the root cause of medical mistakes, from which follows logically the required corrective action, real-time cognitive support for healthcare practitioners, which only real-time IT can provide. Clearly then, cognitive overload is a significant contributing factor to medical mistakes, be they hospital-acquired infections or medications or whatever their procedural cause or result, totaling 440,000 lives annually in the U.S. alone, as previously described. The principal U.S.-based patient safety organizations identified here have developed and/or have advocated tools and methods for medical mistake mitigation that rely on human factors such as leadership and heuristics, all of which vary in efficacy with the nature of the implicated healthcare SMEs and their individual cognitive capabilities. Therefore, these methods not only are unreliable, but also, because of the need for memorization and quick recall, exacerbate what we already have determined is the root cause of medical mistakes, cognitive overload. For example, reference the lower right-hand screenshot on the slide. Handoff communications between hospital patient ward charge nurses is so problematic and contributory to the occurrence of so many medical mistakes that it has been addressed by the Joint Commission, the USA Accrediting Agency for Healthcare Provider Organizations, and its Center for Transforming Healthcare, with a handoff communication specific version of its Targeted Solution Tool, or TST. TSTs in turn are based on the Commission's registered trademark Robust Process Improvement, or RPI, tools and methods, per this quote from its website. Quote, "The Center and its participating organizations use RPI methods and tools to improve quality and safety of healthcare. These methods include Lean Six Sigma and other change management methodologies and tools for high reliability." End quote. Johns Hopkins Medicine's Armstrong Institute for Patient Safety and Quality also relies efficiency and human factor improvement methods in the development of its Comprehensive Unit-Based Safety Program, or CUSP. However, these tools and methods, which include detailed documents and intensive training for targeted process participants, create cognition challenges of their own, and thereby serve to exacerbate the root cause of medical mistakes, cognitive overload, which is further exacerbated by the time-critical and information-intensive nature of medical practice and healthcare delivery, causing cognitive errors such as degraded recall and impaired S1, S2 thinking. Henk van Houten's healthcare IT proposition shown here is the basis, or should be, for the conception and implementation of a digital learning health system that is practicable and scalable. I have positioned his proposed system referring to a rational and coordinated array of standards and procedures, both human and automated, at the quote, integration, end quote, level of the digital transformation pathway or roadmap depicted. To encompass the foregoing three levels, including the connectivity and intelligent integration of existing IT systems and services, is technically doable now, but orchestration of these four levels in a real-time functioning ecosystem is, it seems to me, dependent on the individual and organizational participants, a political rather than a procedural problem. The schematic numbered 1, which is included in the work cited by Dr. Richard Bomer, MBCHB, when he was on faculty at Harvard Business School, depicts the physiology, anthropomorphically speaking, of a healthcare delivery system that is designed to manage knowledge and to incorporate it immediately in the care delivery process. For this concept of a learning health system to be realized, a common suite of digital tools and methods, ideally standardized worldwide, must be available and supported. The quoted content number 2 describes such a suite, has been conceptualized, documented, and currently is evangelized by the Object Management Group, or OMG, Healthcare Domain Task Force, recently reorganized as the OMG BPM Plus Health Community in its 2020 publication, Field Guide to Shareable Clinical Pathways. To understand why and how the tools and methods described in the field guide are essential to a learning health system implementation, please take time to review the 125-page publication, or at least to attend the hour-long webinar, URLs for both of which are included in footnote source 2 on the slide. This schematic, published in the cited presentation numbered 1, is based on R&D work done at the USA Health and Human Services Agency for Healthcare Research and Quality, AHRQ. Make more specific the elements of Dr. Bomer's care design depicted in the LHS cycle and its interactions with external systems and data sources depicted in the right-hand portion of the schematic. The quotation number 2 from the field guide, already cited, summarizes other content throughout the field guide that describes or supports virtually all of the bullet point features under dissemination/implementation, in the schematic. Again, you must be or become familiar with the content of the field guide to understand this relationship, and you will have access to virtually all of the features and functions identified and described in the Do-It-Yourself app free of charge Solution as a Service, SaaS, which is described later in this presentation. The subject of this case study is the cited article from one of the Joint Commission's official publications, which article itself is based on a root cause analysis submitted by an accredited hospital as required by TJC accreditation standards following the occurrence of a so-called sentinel event, which in this case resulted in a patient fatality stemming from a combination of iatrogenic and nosocomial causes. As the excerpt in red on the slide states, quote, "The order set for the heparin infusion was not entered properly, leaving out the automatic order for blood tests every 6 hours. During the handoff report, the nurses did not discuss when the next blood test would occur to monitor infusion," end quote. 3 days later, the patient died because of an immune-mediated heparin-induced thrombocytopenia, aka HIT type 2. Here is a flowchart depicting the sentinel event just described, overlaid on a two-dimensional table of the event process activities, the column headings across the top, versus the actors, the row headings along the left side. The actors include, from top to bottom, the patient, the provider, in this case an orthopedic surgeon, nursing staff on Unit 1, the recovery room, nursing staff on Unit 2, the post-op surgical ward, and the EHR IT system. The process activities are numbered across the top of the chart and described on the right side of the slide as follows. Begin flow of the patient removed to recovery post-operatively. 1. Surgeon orders heparin infusion and Q6H testing. 2. Heparin infusion started but test order not input. 3. Patient complains of headache and discomfort. 4. The nurse notes failure to test and patient deterioration. 5. CT scan ordered and done, confirming intracerebral hemorrhage, and end flow, patient dies and discharge is processed. This is an example of a medical mistake mitigation tool, one of a library of so-called actionable patient safety solutions, or APSSs, trademarked by the Patient Safety Movement Foundation. This APSS is the Foundation's mitigation method for the shift handoff communication case that we are considering. The handoff communication APSS is intended to be studied by all parties involved and then to be executed at change of hospital nursing unit shift, which typically is executed as a conversation between oncoming and offgoing charge nurses during the typically 15-minute shift change period. Because the APSS requires considerable recall, notwithstanding inclusion of supportive mnemonics and other heuristics, and concentration, which cognitive activity is made more difficult because of the chaotic and crowded nursing station, even close adherence to the APSS content provides little assurance that the nursing report will be any more complete, accurate, and timely than usual. Here is a revised sentinel event flowchart overlaid on the same two-dimensional table of activities versus actors as the chart previously presented. But this chart includes an additional actor row at the bottom representing the automated process application labeled APP in red letters. This row describes the app functions designed by a knowledgeable healthcare practitioner SME, which app is running continuously after being started by the assigned staff person, perhaps the surgeon or the recovery room charge nurse. Having been started upon admission to the recovery room, the app monitors actor activities via analysis of updates to the patient's EHR record and other of the hospital's ancillary system data sources, and it interacts with actors in real time as described in the list at the right of the slide as follows. Begin flow, start monitoring and notification app for a specified patient. 1. Monitor patient electronic health record computerized physician order entry for occurrence, accuracy, and completeness. 2. Notify specified staff of noncompliance. 3. Notified specified staff of patient complaints. 4. Monitor patient EHR for order completion update. 5. Notify nursing staff of stabilized blood viscosity. And end flow, stop the monitoring and notification app. One of the features in the app just described is its ability to notify and otherwise interact with the patient's caregivers and other actors, conditional on EHR data value changes, implying critical events that do or do not occur in a correct and timely manner as previously defined by the app that is running since it was started post-op at the beginning of the patient's recovery period. Shown here are 3 mobile phone screens generated by the app. The first, designed for the user to identify the subject patient or to identify the recovery room nursing unit in order to obtain a current unit census. The second, to select the subject patient from the displayed census of the previously designated nursing unit. And the third, both to remind designated staff of critical care data and to inform them in real time of actions to be taken for analysis of the EHR input data as displayed in red font on the right-hand phone image. This slide displays the highlights of a pediatric dosing application called SafeDose Scan, developed and demonstrated by the creator, James Broslow, MD, a well-known retired pediatric emergency room physician. Dr. Broslow, in spite of his long and illustrious clinical experience, knows full well, as did Dr. Weed, that memory and mathematics are the nemesis of practicing physicians. Therefore, SafeDose Scan is designed to perform these functions in determining and administering medication dosing for pediatric patients, the quantities for which are critical because of the small size and low weight of pediatric patients. Please take time to view the brief presentation by Dr. Broslow cited on the slide. Not only does the app do calculations, but also it reads medication barcodes, recovers medication abstract data, takes photos, and generates text from the audio dictation to update the associated EHR record. With few exceptions soon to be resolved, the DIY SAS for healthcare practitioners that I'm about to describe can enable you, the healthcare SME end user, to create an app just like SafeDose Scan, including leveraging of features enabled by digital device hardware and operating system, but without the associated cost and extensive IT expertise required to create the original and any of the several thousand others like it in the current commercial app store. As medical and healthcare SMEs, we must recognize and react to the several opportunities that confront us daily for medical mistake mitigation and case outcome optimization. To do this, we should be as discerning about problem presentation as we are about patient case workups, diagnosis, and treatment planning, being careful to distinguish between signs and symptoms and not to paint failed problem interventions with too broad a negative brush. This slide includes on the left excerpts from a scholarly article regarding the suboptimal results of an artificial intelligence app marketed by the leading EHR vendor, the EPIC sepsis model. Further investigation reveals that it is not the artificial intelligence or AI statistical formulae or IT approach that was at fault, but rather a defect in composition of the patient record cohort on which the AI results depend. By contrast, researchers at Emory University School of Medicine, with necessary medical, statistical, and IT knowledge and capabilities, have reported significant success with their TensorFlow sepsis prediction algorithm, probably because the data and technology were correctly incorporated and applied. Furthermore, the authors correctly identify the TensorFlow critical success factors for real-time sepsis management, as underscored in red in the excerpt from their paper on the right side of the slide. Quote, abstracting away infrastructure requirements, end quote, and, quote, providing information in the actionable window when physicians can take meaningful actions for a patient, end quote. Now let's see how the DIY Apps for Healthcare Practitioners cloud-based solution as a service addresses these same critical success factors. These are the steps you must take to access the Do-It-Yourself Apps for Healthcare Practitioners Solution as a Service, or SaaS. 1. Surf to the URL hcuc.decisions.com. 2. Read and accept the End User License Agreement, or EULA, which underscores the current production code quality but as-is nature of the solution, highlights that this solution as-is does not comply with HIPAA regulations for production use, and that you take full responsibility for the uses you make of it and the results of your actions. 3. Self-register by providing the required data, which may be used for solution management and other purposes consistent with the Decisions LLC privacy policy, published at decisions.com/privacy-policy. 4. Access the combined User Portal and Designer Studio screen. 5. Access complete online solution documentation at documentation.decisions.com to support your app development work. 6. Access a library of publications, videos, case studies, blogs, trainings, and demos at decisions.com to inform your work. Continue without cost to develop and deploy your apps as follows. 7. Select the Designer Studio features as needed to develop your app. 8. Create multidimensional rules and decision tables as needed. 9. Create process workflow diagrams as needed to develop your app, incorporating rules and tables as if needed to enable dynamic decision making based on data or conditions encountered or created previously in the process flow. And 10. Select the End User Portal to utilize included features shown as if needed, and to deploy, revise, or optimize your app as needed at any time. 11. Operate or interact with your or any other app available from an app store via an internet-connected PC, Windows device. And 12. Operate or interact with an app via a mobile device, recognizing that multiple and desktop or laptop devices may be accessed and utilized by the same app as if required by the automated flow, decisions, forms, reports, and other features included in the app. Please log into the Do-It-Yourself Apps for Healthcare Practitioners Solution as a Service, DIY SaaS, today to begin building, free of charge, a digital learning health system by creating and operating the dynamic digital knowledge modules, which are your apps. You may discontinue using this DIY SaaS at any time with the option to migrate your knowledge digital artifacts to your own cloud platform or to a commercial cloud service provider platform, for transition costs to be negotiated with Decisions LLC and operating costs to be negotiated with Microsoft or Amazon for either of their HIPAA-compliant cloud platforms, Azure or AWS, respectively. Thanks for your time and attention in contributing to a global digital learning health system that will transform the healthcare domain by enabling you and other healthcare SMEs to create and operate apps, and thereby benefiting patients by mitigating medical mistakes, maximizing care cost benefit, and optimizing case outcomes. Good wishes for continued success and satisfaction in your vital healthcare endeavors.